Hi guys, welcome back to G Chats with your host G, and we are back in the G spot. And today we are talking about endometriosis. If you didn't know, March is Endometriosis Awareness Month. So my team and I just figured it made perfect sense to do an episode about endometriosis because unfortunately, endometriosis affects 200 million people worldwide, and yet it still remains deeply misunderstood. So endo is often brushed off as just like bad periods. And I want this episode to kind of break that down because that's not what endo is. It could be responsible for some people having very bad periods and very painful periods, but that's not the root of what endometriosis is. And I just want to use this episode to basically shut down the outdated and debunked theories, bring awareness to the debunked theories. So if you've ever had your pain dismissed and you are someone struggling with endometriosis, you know someone struggling with endometriosis, share this video with them. Let's have conversations in the comments section and let's talk about this hidden epidemic because 1 in 10 women and people assigned female at birth have been diagnosed with endometriosis, but the actual number is likely higher because of delayed diagnosis. And if you didn't know, most of the diagnosis that is delayed takes 7 to 10 years to actually get the diagnosis. And there's plenty of celebrities that suffer with endometriosis and they're very outspoken about the limited research and the limited care that exists for endometriosis. So I think that we definitely need to bring more awareness to it because despite endometriosis being one of the top 3 causes of infertility, endometriosis receives significantly less research funding than male reproductive conditions like erectile dysfunction. So it's clear that there's a discrepancy with how female reproductive health is cared for and researched, and we already knew that. But I think that's why it's super important to utilize this month to raise awareness and give science-backed information about what endo is, because there's so much misinformation and it's incredibly misunderstood. And I think there's a lot of people who think they have endo, but don't even really know the full scope of what endo is. So let's start off with what it actually is and what endometriosis consists of. So we're going to be debunking the basic definition, and that basic definition is basically that endometrial-like tissue grows outside of the uterus. So essentially this narrative, and I think the terminology of endometriosis is misleading because most of us know that the uterine lining, so the lining inside of our uterus, is known as the endometrium. And so a lot of people think or are told that this is basically that tissue that grows outside of the uterus, right? That's kind of the narrative and the logic. Oh, it's endometrial tissue. So the tissue that lives in the uterus that's just now growing on the uterus and the fallopian tubes and the ovaries. But that's not true. And it's because this tissue that when we refer to the tissue in endometriosis, it's known as ectopic endometrial-like tissue, which means that it resembles the tissue that's inside of the endometrial lining. So it resembles endometrial tissue, but it behaves different. So it's not endometrial tissue. It looks like it and it's similar to it, but it's still different. And that's because it behaves differently in the sense of it has its own blood supply and it even secretes its own inflammatory chemicals, and this fuels disease progression. So endometriosis, contrary to popular belief, it doesn't just grow on reproductive organs. It has been found in the lungs, in the diaphragm, on the brain, and even in surgical scars. So there's a misconception that it is a uterus-specific disease and condition, and it's not. Endometriosis tissue is different than the endometrial tissue, and beyond that, this tissue that we talk about when we're talking about endometriosis goes on other organs. It grows on other organs. It grows on the ones that we talked about. So it is different, and I feel like that expands the information, and that's really left out when we're talking about most times endometriosis. Now, there's also outdated theories on what causes this. So a really long time ago, retrograde menstruation was the myth that was used to explain why endometriosis happens. And if you didn't know, retrograde menstruation is when menstrual blood in your uterus flows backwards into the pelvis. And this was considered to be the reason that endometriosis happens. And this is because endometriosis for years and years and years has been consistently linked to a uterus problem. And we know that it's not, because this tissue is growing in many other organs, not just the uterus. And so this explanation doesn't make any sense. And furthermore, it doesn't make sense because 90% of people with uteruses who have a period, it is just natural based on our female anatomy that menstruation blood will flow to the back of the pelvis. Like that happens just by having a uterus and menstruating. But yet only 10% of people will develop endometriosis. So if retrograde menstruation was the cause of endometriosis, we would see pretty much every single person with a uterus having endometriosis, and that doesn't exist. So that's like a very outdated myth. So newer research and what researchers are now thinking is embryonic cell therapy. So this is cells from early fetal development that lay dormant. And this is present. We see things with like cancer and stuff like that there's a lot of cells that just lay dormant and then suddenly they're activated decades later due to inflammation or even hormonal triggers. So that's a potential theory that essentially you're born with it and it's just dormant until it triggers. Another theory is stem cell theory, and some research suggests that stem cells from bone marrow could migrate and contribute to endometriotic lesions. We're going to talk a little bit more about these lesions, but there's also recent genetic studies that are suggesting that endometriosis is linked to mutations in genes like the WNT4 and the HOXA10 genes, which influence reproductive organ development. So there's different studies that are trying to look into beyond just the uterus, right? Like we have our ovaries, we have our fallopian tubes, we have other reproductive organs. And then beyond that, we have other organs that are being affected when it comes to endometriosis. So I think research is becoming more comprehensive to understand this issue at beyond just a uterine lining issue, because we know that that's not what endometriosis is, and they're very different actually. So we will get to that a little later. Another thing that we are now seeing is that inflammation and the autoimmune condition is linked together. So endometriosis does behave like an autoimmune condition, and this is because immune dysfunction prevents the body from clearing ectopic tissue. So when the immune system is functioning properly and as it should be functioning, essentially when ectopic tissue is present, the immune system naturally clears that tissue. But in people with endometriosis, the immune system isn't clearing this ectopic tissue. And so this kind of highlights to us scientists like, okay, there must be some dysfunction with the immune system that it's not recognizing this and not clearing it on its own. Additionally, there are studies that are showing higher levels of pro-inflammatory cytokines in people with endo. So this can actually cause chronic pain, fatigue, and systemic inflammation, which is all symptoms and things that we see with people with endometriosis. Now, I know I just mentioned a few minutes ago the difference between the uterine lining and endometriosis. So that leaves me to this point where we need to distinguish the difference between endometriosis and adenomyosis. So the thing that a lot of people don't realize is, again, endometriosis tissue grows outside of the uterus and it can cause organ adhesions. So if you were to look up a picture of organ adhesions, what you'll see is adhesions, which are bands and web-like scar tissue. That's what the medical terminology of adhesions are. These bands of scar tissue and this like web basically connects specific organs or different organs in the pelvic cavity, such as the uterus, the fallopian tubes, and the ovaries, and it connects them to surrounding tissues. So the surrounding tissues in the pelvic floor are now like essentially webbed with these organs. And that's what we see with endometriosis. We see these adhesions that happen, and you can also see these adhesions with pelvic inflammatory disease. So it's basically webbing and connecting connective tissue that's basically like binding tissue with organs through scar tissue, aka adhesions. Now, interestingly enough, adenomyosis is endometrial-like tissue that grows inside the uterine walls, and this is what makes periods extremely heavy and painful. So I have a problem with the medical community because a lot of times, if you know somebody who's having severe cramping, severe periods, heavy periods, everyone's always like, you must have endometriosis. And that endometriosis itself is not directly, it's not the cause of the heavy, painful periods. Adenomyosis is what's causing the heavy periods. It's important to note that over 40% of people with endometriosis also have adenomyosis, but doctors often fail to check for both. They will just blanketly say, oh, you have endometriosis. But adenomyosis is what is actually causing the uterine lining to be extraordinarily thick, and that thickness is what's causing the extremely heavy and painful periods. So while adenomyosis can frequently coexist with endometriosis. And as I said, over 40% of endometriosis cases do have adenomyosis. It can also occur independently. So it's really important to distinguish between the two and understand the difference between the two and not just blanketly assume. And I think that's just what we see is, oh, painful periods, heavy bleeding, endometriosis. But no. The painful, heavy bleedings is adenomyosis, which can often be accompanied with endometriosis. So that needs to be understood. And unfortunately, this leads to medical gaslighting and delayed diagnosis because many patients are told that painful periods are normal. But again, period pain is normal, but period pain that interferes with your daily life is not. And some are misdiagnosed with IBS, UTIs, or even mental health disorders before getting the real answer. So you might be thinking then, like, what is the gold standard? How do we diagnose endometriosis? The gold standard is a laparoscopic surgery, and this is essentially when they go in and they look at the uterus and those surrounding organs and look for the tissue and look for the lesions, because many doctors rely on ultrasounds, and ultrasounds miss endo lesions all the time. So it's really important to, unfortunately and fortunately, advocate for yourself, because traditional ways of looking for endo is very outdated. So this leads me to the hormonal hellscape of endometriosis, because a lot of people don't realize your hormones are incredibly connected to endometriosis. But a lot of people, again, think that endometriosis is just another estrogen problem. And the reality is that it's far more complex, because endometriosis lesions, the lesions themselves, so the lesions that we might see on the brain or in the lungs or on the uterus, the fallopian tubes, they produce their very own estrogen, and it's a local aromatase activity that happens, and this makes symptoms even worse. And this is exactly why hormonal birth control does not work for people with endometriosis lesions, because it reduces ovarian estrogen, but it doesn't stop the local estrogen production. So unlike PCOS, where testosterone is often too high, endo sufferers often have testosterone deficiency, which leads to fatigue, muscle weakness, and low libido. So this also explains why progesterone resistance is very common and why birth control fails for many, because there's estrogen progesterone combination, or there's progestin only birth control options, and both don't really help with endometriosis. So specifically specifically when we're talking about progesterone, in a healthy cycle, progesterone suppresses inflammation naturally. But when you have endometriosis, the cells become resistant to progesterone. And this means that synthetic progestins that are found in birth controls, like the pill or even the IUDs, they don't effectively control the symptoms, and the body is resistant to the synthetic hormone. So this then leaves cortisol levels to thrive and flourish, and this worsens endometriosis. So chronic pain from endo increases cortisol levels, and this disrupts ovulation, and as I said, worsens pain, but also worsens inflammation. So many with endo develop HPA axis dysfunction, which is the hypothalamic pituitary adrenal axis dysfunction, and adrenal fatigue, and this leads to constant exhaustion. And endometriosis is a full body inflammation disease. And that's not talked about enough. It's not just a reproductive disorder. High cortisol from the chronic pain leads to increased gut permeability, which is also known as a leaky gut. It worsens inflammation, and we also see increased prostaglandins, which intensifies cramping and period pain. So unfortunately, cortisol does play a role when we're talking about endometriosis, and it does cause inflammatory markers that we see in these patients. There's also histamine overloads and mast cell dysfunction. So have any of you ever noticed bloating, skin flushing, or even migraines with your cycle? If the answer is yes, that is because endo lesions are packed with mast cells, and this can trigger histamine responses that show up in those symptoms, which is bloating, skin flushing, and migraines. Additionally, this does explain why so many people with endo also have food intolerances, IBS, and even allergies. So unfortunately, testosterone deficiency is something that we see in endometriosis as well. And I talked about this in the PCOS episode, but this is why I say very, very often that your endocrine system is literally a system, and it's a bunch of wheels that spin together. And when one of those wheels is messed up, all the other wheels get thrown off as well. And that includes testosterone. There is testosterone deficiency, and people with endo often have lower free testosterone. And this leads to muscle weakness, slow recovery from exercise, and a low libido. This is rarely discussed, even though we have seen some research showing that testosterone therapy has helped some improve pain and energy levels. So we need to talk about endo's impact beyond just period pain. And I really wanted to talk about this because, as I mentioned, endometriosis is repeatedly connected and correlated to a uterus problem and a reproductive problem, a period problem, and it's not. So overlooked symptoms that no one talks about is neurological symptoms and the nervous system. So endometriosis has been found on the sciatic nerve, which causes leg pain, numbness, and even difficulty walking. The condition can mimic conditions like interstitial cystitis, pudendal neuralgia, and even irritable bowel syndrome. So again, this tissue isn't just tissue that grows exclusively on the uterus. It's growing on the sciatic nerve in some cases. It's growing on the bowel. It's growing on the brain, the lung. Like, this tissue is different than just tissue inside of the uterus or tissue that is inside of the uterus and now growing on the uterus, outside of the uterus. No, this is tissue that is functioning abnormally and growing on different organs, different nerves, different tissues, and causing serious issues that now can mimic other health issues. And this allows for misdiagnosis. We also know that there's a connection between the microbiome in the gut and gut dysbiosis. So people with endometriosis have significantly altered gut microbiomes with lower diversity and higher inflammation markers. And many people experience SIBO, which is small intestine bacterial overgrowth, and severe bloating, which is often misdiagnosed as IBS. We also know that there's a connection here or something to be said about immune dysfunction and allergies because endo sufferers have higher rates of allergies, asthma, and autoimmune diseases. And some experts believe that chronic mast cell activation is linked to histamine intolerance, which worsens inflammation and pain. We also know that there are some cardiovascular risks associated with endometriosis, and that's because long-term studies have shown an increased risk of heart disease, stroke, and high cholesterol in people with endometriosis. And this is possibly, in my opinion, due to chronic inflammation. So there's just a number of impacts of endometriosis that goes far beyond just period pain. And these are things that are very, very, very overlooked when we are dealing with female patients experiencing these symptoms and these issues. And so, unfortunately, traditional treatments have been failing us. And let's talk about why. So, traditional treatments are birth control, Lupron, or Orilissa, and they only suppress symptoms. They don't remove the disease. And that is because all of these drugs induce medical menopause. Yes. They basically put you in menopause, and that is because they suppress ovarian function. So they don't necessarily stop the endometriotic lesions from growing. They just suppress your ovaries from functioning, and they induce medical menopause. And there's also long-term risks like bone density loss, severe depression, and increased cardiovascular risks with Lupron. So we don't see any true restoration or anything positive that's happening with these other than like just suppressing the symptoms. They think that putting you through menopause will basically effectively suppress these symptoms. And suppressing symptoms is fine, but it's not getting rid of the lesions that endometriosis tissue is causing. So many doctors still push then a hysterectomy as a cure, but that is a myth, and that's because endometriosis can persist without a uterus, because we already said endometriosis tissue can grow on other organs like the lungs, the bowel, the sciatic nerve, other things beyond just the uterus. So the idea that taking out the uterus is going to solve the problem is not helpful. It can solve the problem for people with adenomyosis, but not those with endometriosis. And so the next step, and another thing that's talked about, and it's so outdated, is an ablation. So if you don't know what an ablation is, it's a medical procedure that involves destroying tissue using various methods. They can either use heat, cold, or electrical energy to basically destroy, burn off, damage the tissue. And so when we're talking about endometriosis or gynecological procedures, the term is typically referring to endometrial ablation or ablation surgery for endometriosis. But the issue that I have with it is that endometrial ablation will usually be something that's done for heavy periods and not for true, real endometriosis. So, as I said, this endometrial ablation will basically remove or destroy the lining of the uterus. They go into the uterus and they will destroy the endometrium to reduce or stop heavy period bleeding. However, this is not a treatment for endometriosis because we know that endometriosis is endometrial-like tissue that's growing on other organs. So this only addresses heavy periods, but it does not address endometriosis. So that's why the difference between endometriosis and adenomyosis is so important to know, because ablations will address that, adenomyosis, but it's not addressing true, real endometriosis. But unfortunately, endometriosis is so misunderstood that people think it's adenomyosis, and that's why ablation therapy and ablation treatment and surgery has been used for years and years and years, even though we've seen it to be not successful. So you can use it for people with extremely heavy periods and they don't respond to medications. And again, if you are having a very, very heavy period, that is because your uterine lining is thickened. And when the uterine lining is thickened, this is making your period more painful and more heavy. But it's also not recommended for people who do want to get pregnant in the future, because pregnancy after an ablation is very, very dangerous. And I've talked about this before, but when an egg gets fertilized in the fallopian tube, the idea is now it's traveling to the uterus and it's going to embed itself in the uterine lining. And when your body is getting ready for either your period or pregnancy, the uterine lining is thickening. So there's hormones that are making the uterine lining thicker so that it can basically accept a fertilized egg. What happens is when this egg gets to the uterus, either it attaches to the uterine lining because it's fertilized, or the body recognizes, oh dang, the egg's not fertilized, and then it sheds the egg and degrades the cell lining and the tissue. Now, unfortunately, for people with adenomyosis, they have like an absurdly thick uterine lining that's causing super heavy periods, super painful periods. And so if you do an ablation to address adenomyosis, you are burning the lining of your endometrium, the uterine lining. And so if and when you do get pregnant, you don't have a thickened uterine lining anymore. And so that fertilized egg kind of has nothing to embed into and grow into, and there won't be a successful embedding of the uterine lining. And so it makes it very dangerous, because you can have a fertilized egg that's sitting in a uterus that doesn't have a uterine lining. So basically you will kill the fertilized egg, because there's nothing to now feed nutrients to the fertilized egg, because the whole reason the egg wants to connect to and embed into the uterine lining is because that uterine lining that's filled with blood and nutrients and even stem cells, those things feed and nurture the fertilized egg. So if you don't have that healthy and lush and thickened uterine lining, well, then it can't really feed and nourish a fertilized egg. So obviously, adenomyosis is beyond normal uterine thickening. It's when the uterine lining is abnormally thick, because everyone's uterine lining is supposed to get thick naturally getting ready for pregnancy or sheds during a period. So even normal hormone levels and regular periods and normal periods have uterine thickening, but it's still it's different, because adenomyosis is abnormal uterine thickening. And so ablations are meant for those people, but just really think about the fact that if you do go ahead with the ablation, you likely shouldn't and can't get pregnant. So if you plan on getting pregnant, I would steer clear from the ablation. So the issue is that it's not a cure, of course, for endometriosis, and it's honestly not really a cure for adenomyosis either, because if someone has adenomyosis, which again is endometrial tissue growing into the uterine muscle, an ablation doesn't reach deep enough into this muscle to remove it. It just trims the uterine lining. So it just really destroys the uterine lining, but the adenomyosis tissue that is overgrowing in the lining can also extend deeper into the uterine muscle. And if you have endometriosis, well, ablation does literally nothing to treat the lesions outside of the uterus. Because again, I will say it multiple times in this video, endometriosis is when the tissue, this tissue that we see, is growing on other organs, not just the uterus. And so some people experience worse pain after an ablation if the remaining endometrial cells become trapped. And additionally, we know that ablation surgery for endometriosis does nothing. It's an outdated approach, because doctors will essentially burn or cauterize the endometriosis lesions. So if a doctor recognizes and says, you know what, yeah, endometriosis isn't just a uterus problem, and endometriosis tissue grows on other organs, what they will do is they will go to those other organs and they will burn or cauterize the lesions, and they will do that with heat, laser, electricity, whatever. And so what happens is, let's say you have endometrial like tissue that is growing on the lungs or the diaphragm. They will take this device and burn and cauterize the tissue on whatever organ endometriosis is present on. However, it only destroys the surface of the lesion and it doesn't remove the deep roots, which can continue to grow. And unfortunately, up to 80% of patients see their symptoms return within a few years. And the best way for me to sum this up, and I made this analogy that I wanted to share with you guys and I wrote down, is basically imagine that you have a tree that's growing in your backyard, right? And you want to get rid of it completely. Like you're tired of the tree, you want to get rid of it. So now if you just take a chainsaw and you cut off the branches or even chop just the trunk halfway down, what happens? I'll give you a moment. Okay, so the tree grows back. The tree keeps growing back because the roots are still deep underground and it's feeding it. It's feeding the tree. And so unless you completely dig up and remove the roots, the tree will come back, sometimes even stronger. And this is exactly what we see and how endometriosis works. When doctors use ablation, they're basically just burning the visible parts of the lesion, just like chopping off maybe just the branches of the tree, but the deep roots of the lesion are still there, buried in the tissue, and they continue to grow and spread. So over time, endometriosis comes back just like a tree that wasn't fully uprooted. So that's why excision surgery, which we will get to in a minute, is the gold standard. Instead of just burning the surface, an experienced excision surgeon actually cuts off the entire lesion from the root and prevents it from growing back. And that's the difference between truly removing the problem and just temporarily trimming it down. So that's the thing, is ablation can be used and is mostly used in the uterine lining for adenomyosis. But if you have a doctor who says, actually, and they recognize actually endometriosis is endometrial-like tissue that grows on other organs, if they recognize this and still want to do an ablation, it's still flawed and it's still wrong, because the ablation is not getting to the roots, like the roots of a tree. It's literally just cutting the surface. And so if you don't eliminate the roots and get rid of the roots are still going to grow and spread into other organs, even if you trim the surface. So I am not for ablations at all. I am pro excisions, and we will talk about it, because the key takeaways is that endometrial ablation is not a treatment for endometriosis, and ablation surgery for endo does not fully remove the disease, and it has a high recurrence rate. So let's talk about what excision surgery is. So excision surgery is the gold standard because it completely removes endometriosis lesions from the root, and it reduces the recurrence rates to 10 to 20% in comparison to an ablation, which has a 60 to 80% recurrence rate. An ablation can cause scarring and nerve damage, and it makes future surgeries even more difficult, unlike an excision. The only issue with excision is that there's a handful of surgeons in the world, just a handful, that are trained in true excision surgeries. And this is why so many get ineffective surgeries, because they will go to doctors who try to perform this, or there's just no surgeons around them locally to perform this. There's, again, just a handful worldwide. There's also new treatments that are showing nerve block therapies and even pelvic floor therapy to be helpful with endometriosis. So endometriosis can unfortunately entrap the pudendal nerve, and this can lead to pain during sex, pain during urination, and even pain when sitting. So pelvic floor therapy can help release muscle tension that is caused by chronic pain. We also know that there's diets and supplements that show promise in recent research. Anti-inflammatory diets that are low in histamine, gluten-free, and dairy-free can help reduce flare-ups. NAC is a supplement that in a study has shown that 24% of people avoided surgery after using NAC for 3 months, which is promising. We need more research, but that is promising in the study. There's also been curcumin research from turmeric, which blocks inflammatory pathways driving endo growth. So if you can block the inflammatory pathways, you can potentially stop endometriosis in its track from growing, that tissue from further growing. So I would say try curcumin for those of you who do have endometriosis and it is spreading. There's also quercetin, which reduces histamine overload and inflammation over time. So that's also been very promising, and that is inside of Thrive Immunity, the product that I have, the immune boosting supplement product that we have. There's also future breakthroughs that are showing microRNA therapy and epigenetic treatments. Some research is believed to be targeting specific microRNAs that could halt endo progression and endometrial tissue growth without hormonal suppression. So there is more research that's being done of how we can truly treat it, because a lot of people don't have access to excision surgery, and if they don't, it's what are the other options? So in the meantime, we know that pelvic floor therapy and nerve blockers have been promising, certain diets, certain supplements, and there is more testing that's being done to really look at the microRNAs, and we want to kind of stop endometriosis, the tissue in endometriosis, from growing and expanding to other organs and sticking and causing adhesions. So ultimately, endometriosis is not just a bad period. It truly is a systemic inflammatory disease that requires real research and real solutions. So I hope that this episode did resonate with a lot of you if you have endometriosis or you know somebody that has endometriosis, because ultimately this is super misunderstood, understudied, and not talked about enough, and it is stigmatized as just being a period issue. And if you're having painful periods, it's oh, suck it up, it's normal, and it's not. And there's a lot of just misconceptions and mistruths about endometriosis. So I hope that this video was helpful for understanding endometriosis and raising awareness to it. And again, it is Endometriosis Awareness Month. So I am going to be making more videos about endometriosis on my TikTok, and basically maybe clipping this podcast episode to share that information. But I really hope that you guys enjoyed this episode. That's really all I had for today. I really just wanted to go through those things that I had in my notes. But I love you guys so, so much, and I will see you in the next episode next week. Bye, guys.